TopMed Talk. Monty Mythen, Editor-in-Chief of TopMed Talk, and I've just caught up with Professor Mike Grocott, who is a Professor of Anaesthesia and Critical Care at University of Southampton, a regular on TopMed Talk. And we've just been in the poster session at the International Anaesthesia Research Society here in Chicago in the USA, where we're both speaking in a session later on about perioperative medicine. And we've just been privileged to see the results presented of the METS trial. Now, the METS trial is under review for journals at the moment, so to be respectful to the authors and to the journal and everyone involved and to the IARS, we're not going to give you the results, but we are going to discuss the trial design and whet your appetites about some of the really, really interesting data we've just seen presented. So Mike, tell us a bit more about the METS trial and why it was needed, why it was thought to be necessary.
So the METS study, which was initiated by Brian Cuthbertson originally when he was in Scotland before he went across to Canada, now led by Brian and Daminda Wijasundera, was originally designed as a comparison of different methods of preoperative risk assessment. So in particular cardiac biomarkers, objective evaluation of exercise using cardiopulmonary exercise testing, and then more subjective evaluation of exercise using a particular score, so the Duke Activity Status Index.
So just going to interrupt for a second there, Mike. The markers, now not everyone's going to know about these markers. We've heard about some of these things. So these are blood tests that are performed to measure the levels of naturally occurring substances in the body that change. The levels change if, for example, your heart is failing. Is that?
That's absolutely right. So N-terminal pro-BNP, so brain natriuretic peptide, is a substance that, if elevated, gives you an indication that there may be some cardiac failure there.
So sorry, Mike. So when we talk about the BNP as we go forward, that's the marker of possible heart failure. Even though it's a brain natriuretic peptide, it's known to go up when the heart is failing. It's a bit like creatinine goes up if the kidneys are failing.
Yes, and the feeling is that it's a relatively... If the number's low, then you can be reasonably confident that there isn't cardiac injury. If the number is high, then there's a bit of complexity around interpreting what that number means.
And the other thing you mentioned, which we've talked about a lot before, is this cardiopulmonary exercise test, which is bring somebody in, put them on a bicycle and do something you see athletes doing.
Exactly so. It's exercising, typically it's on a bike, exercising progressively to maximum exertion, and you measure the oxygen consumption, carbon dioxide production and some other variables, and give you a measure which is exactly the same as that which you would measure in elite athletes.
So what I know about, a little bit I know about this already, is that the literature has suggested, one, that the BNP measure can predict outcomes after major surgery, and there's another camp who may or may not believe that is the best test to do, who think that this objective test of exercise, this CPET test, is a good predictor of outcomes after major surgery.
Absolutely so. And particularly, there's a bit of a tension here between the kind of North American view where cardiac pathology and cardiac morbidity is considered to be the major driver of post-operative harm, and a view outside North America which is less convinced that that's the case, and so the biomarkers are particularly believed to be particularly associated with cardiac injury, whereas the cardiopulmonary exercise testing literature has been much more about overall complications and morbidity and mortality.
So when they've looked at the exercise testing, it's predicted bundled all forms of major complications, of which in the literature that we've been involved in collecting in Europe and other people have collected over the decades, it's been the sort of infectious complications, kidney failure, lung failure, have dominated the short-term complications, morbidity, whereas there's a lot of emphasis in the USA literature about heart attacks, let's call it myocardial infarction, but in particular this troponin rise post-operatively badged as MINS. That seems to be part of the evolving story as well.
I think you're right. I think it's intriguing, separate from METS. If you look at the sort of blood pressure studies, so IMPRESS, Emmanuel Foutier's study, obviously not American, French study, and there's very little evidence of myocardial injury, heart attacks, whereas you look at some of the Daniel Sessler's North American data, and one of the dominant themes is myocardial injury associated with low blood pressure. And it's hard to understand why there would be that difference, but it does seem to be reasonably consistent across the literature, comparing between the different territories and across the years.
And you've done a lot of work in the development with others of the perioperative or the post-operative morbidity score, POMS. So you collected data on thousands of patients. What were the big players? And that was collected both in the USA, originally at Duke, and in the UK and now around the world. What are the big players? And we have to remember the fact that these are morbid events occurring relatively close to surgery. What are the big players in those sets?
So to backtrack a bit, POMS originally defined from patient interview was what they thought was keeping them in hospital, and then set of criteria put against different domains. What you see in North America or outside of North America when you use the POMS is high levels of gut dysfunction, high levels of renal dysfunction, high levels of infectious complications and pulmonary complications, and relatively low levels of cardiac and neurological morbidity. Now, the primary outcome variable for this study, I think, is mortality, is death, and some other composite outcomes. And the literature we see from the worlds that we work in is the expected mortality rate is around the sort of 3 to 5% level. For major surgery, and obviously it depends on your inclusion criteria for the study, but for major surgery, short-term mortality, so in hospital or 30-day, I think typically now we're looking at 0.5 to 1%, unless you're enriching for a high-risk population. And then at a year, which was the second time point that METS looked at, you might be looking at double that or a little bit more, so 2-3%.
And the incidence of these major morbid events in the short term and the long term from the existing literature?
A little bit more complicated because depends how you measure it, but as a rule of thumb, about 10 times the mortality. So,
to go back to METS, remind us again why we need the study, and then tell us about the study design.
So this is a study all about risk before surgery, predicting outcome, and then there's obviously a whole load of areas of interest about what you might do with that information. And it's essentially a comparison between the cardiac biomarkers we just talked about, cardiopulmonary exercise testing as an objective measure of physical fitness, the Duke Activity Status Index as a score that might be able to collect that information more simply, and then we added in very early on the straightforward clinician assessment. So what's the end of the bedogram, if you like? Is this patient fit or not fit?
So the people who are less keen on doing, whether it's the blood tests or the bicycle tests, what they often tell us is that they can spot patients who aren't fit. They do an eyeball test and they ask some questions, and they seem to be very confident in their pushback on the more objective tests, that they're very capable doctors, clinicians, nurses, and all that nonsense isn't necessary because they're good at this.
You're absolutely right, and that's interestingly based on very little literature. There's a little bit of surgical literature looking at that alone, so not comparing physician assessment with other measures, but there's remarkably little comparing our subjective assessment with more objective data.
And the METS studies explored all of those elements. So tell us, without giving anything big away, a little bit about the numbers that were involved, the number of countries involved, how long it took to do the trial, and any of the challenges that came across en route.
So it's a multi-centre international study of patients undergoing elective major surgery. The three geographies involved were Canada with Daminda and Brian Cuthbertson, the United Kingdom where Rupert Pearce led that, and then Australia and New Zealand with Paul Miles leading in that territory. All the patients had an exercise test, had the blood test drawn, had the DARSI and the subjective score, and then they were followed for a year. The primary outcome was mortality, or a composite of mortality and cardiac injury at 30 days, but we also looked at complications in general, in fact, using the post-operative morbidity survey, and then we looked at everything again at 1 year follow-up. And
so obviously the results have just been presented here in abstract form. So there will be people seeing the results at the International Anaesthesia Research Society, and that poster, I presume the abstract will be published at some stage, but what we're really waiting for is to see the paper which has the real full results in them. And I got the impression that's under review at the moment, and we're hoping that we'll see that paper and all the results soon.
So I think we're very optimistic that the paper will be out soon, and of course Daminda has an oral presentation tomorrow on one of the prize sessions.
So the good news is, because often with these very big trials which are quite pragmatic, and how many is the total number you said in the end?
Was the total number, the plan was to recruit just over 1,700 and that ended up being included just over 1,400.
So this is another one of those very big trials that should be definitive, so it will give us answers, and we know there are answers. So what we've seen is p-values that have more noughts than the magic number, less than the 0.05, so there are results in here that are going to inform us about our practice going forward.
You might say that, but I couldn't possibly comment. But I would encourage people to look out for the paper because I think they'll find it really interesting. Okay, so please thank Mike. Thank you very much indeed. We're going to discuss, as soon as the paper comes out, we're going to discuss all of the details in a full journal club on TopMed Talk. Please do come to that. Please do come and visit our website if you haven't been there before, www.topmedtalk.com, and join us at one of our upcoming meetings at ebpom.org. You'll find those, evidence-based preoperative medicine, and also at very many other meetings recording, like this wonderful International Anaesthesia Research Society meeting we're at the moment. We'll be at the Royal College Anaesthetists meeting in London coming up soon. Any final comments, Mike? No, very interesting to discuss this paper. Really looking forward to when the data's in the public domain and we can all have a good conversation about it. So this has been tricky, hasn't it? Because this is a bit like those radio discussions where you talk about the novel that's just been published that's on the table, but you want people to read the novel, not tell them if the butler did it. Well, so I'm very glad that we deliberately stepped away from the poster, so there wasn't the accidental risk of disclosure. But no, it's been good to talk, and I look forward to doing the Journal Club. And if anyone would like to contact us, you won't be getting anything from either of us about the results of this paper, correct? Silent. Thanks very much. Bye-bye. TopMed Talk.
And remember, you can join the TopMed Talk team live at one of our many broadcasts. Go to ebpom.org for more details. We're going to be in London on the 4th to the 6th of July for EBPOM in London 2018. Come along and see us. ebpom.org for more details.